So today we're talking about isolation and loneliness, and certainly this is a big deal in our older adult population without COVID happening, but it's really heightened and exacerbated with this pandemic and the way we've had to isolate to prevent infection. So next slide. What can we do, or what do we know about social isolation and loneliness in older adults? And we certainly know that, like I said, without the pandemic, oh, my video got in the way here. There we go. That older adults are vulnerable even without the pandemic going on. Next slide. So there's a difference between loneliness and isolation. You can experience loneliness even if you're in a group of people, right? So it's a perception of being socially isolated. And conversely, social isolation, you have to have the actual physical separation. So that's kind of the difference between the two, but they both have similar effects. Next slide. This slide just shows how the low social activity can reduce cognitive and physical function. And so the more isolated you are, the more likely you're going to have frailty and falls and cognitive changes, mild cognitive impairment, dementias. And I think I've also seen in talks really neat, there was a study done that I think they put kind of tracers on a bunch of older adults, and they saw, what's their spread or their movement in the community. And basically it showed a similar thing. If you are isolated and not moving out of your home, so you just have a really small footprint in wherever you live, right? Then the more likely you are also to have these conditions, so cognitive and physical problems, and more likely to be hospitalized, etc. So it was just a different way to show if you have a large footprint and you're moving all about the city and getting out there and getting around, then you're less likely to have problems with frailty and infection and heart attacks or all those kinds of things that we talked about in the poll. So your footprint on the area that you live also matters. So next slide. Which I think, that footprint is small for those people in a nursing home. They don't often get out, right? So that's already limiting their footprint and causing problems with loneliness and isolation. So like we said in the poll, loneliness is associated with depression, cognitive impairment, premature death, despite, whether they have chronic diseases. Cardiovascular disease can increase risk for heart attack and stroke. It increases your risk for infections because of the immune system, and can increase your risk for cancers as well. Next slide. So there's a loneliness scale, and they have several different versions of this, but certainly you cannot find these online, and they've been validated to show that the answers to these questions increase your risk for loneliness, and then we should do something about it, right? But how often do you feel that you are in tune with the people around you? How often do you feel that you lack companionship? How often do you feel that there is no one you can turn to? How often do you feel alone? Do you feel a part of a group of friends? How often do you feel that you have a lot in common with the people around you? Do you feel that you are no longer close to anyone? How often do you feel that your interests and ideas are not shared by those around you? And you can read the rest of the questions, but just different ways to get at, are you lonely? And like I said, the loneliness, you can still be around people quite often and be considered lonely. Next slide. And there's certainly evidence that if you are in communities and a high socializer, then you are going to live longer. And I like the studies that the Blue Zones did. So there's a group that studied the places in the world that have the longest living people. So there's about 7 of those, and all of those, and then they went in and studied, what's different about these communities that people are living longer. And one of the big things is the sense of community and socialization. And so the one place in the United States that's a blue zone is Loma Linda, California, which is a Seventh-day Adventist community. And so they just have a really good sense of socialization and community there, among with several other things that increase longevity. But those studies from the Blue Zone, they wrote a book about the Blue Zone, and they have a cookbook. And I think it's just a really neat study that shows all the things that help us live longer, healthier lives. And certainly socialization and sense of community is a big part of that. Next slide. Families are, play a huge role, especially in our residents in the nursing homes. And there's several different types of support that are provided by the care workers in the nursing home plus family, and who is providing these different types of support. There's emotional, instrumental, so help with activities of daily living, getting to the bathroom, brushing your hair, those kinds of things. Informational support, and financial. I think we dig a little bit deeper in the next slide. So emotional support is, what it sounds like. They're providing caring, love, concern, empathy, and certainly we can provide that at the nursing homes as far as staff, but family plays a huge role in that. Next slide. So like I said, instrumental support is, helping with personal items, getting toileting, doing your hair, all those activities of daily living. Next slide. Information support, help with managing wealth and property, decision making, and kind of what matters most, end of life care, those kinds of things. Next slide. Financial support, transferring money between generations, insurance, dealing with insurance, and all of those things. So our social workers often help if family's not available to do those things. Next slide. If you are requiring more help with the instrumental, so activities of daily living, then you're more likely to feel sense of helplessness, low autonomy, and reduced self-efficacy. Certainly there's a sense of loss of control, and that makes sense, I think. If you're not able to do those basic things for yourself, then we start to feel a loss of control, and isolation is part of that. Next slide. There's been several studies, and it's certainly stereotyping a bit, but I think there's lots of studies that prove that you're probably better off having a daughter if you're going to need help the older you are, because they'll provide you a bit better support. Although I've seen, and I'm sure you all have too in the nursing homes, very supportive sons as well. But we kind of just by nature have different ways we support. So sons focus more on mobility and environment, and daughters on social, emotional well-being. It's interesting that adult children are less likely to engage with divorced parents. And older adults, certainly if you have more children to pay attention to you, then probably you're going to get more attention, right? There's fewer children, probably not as much as attention and visits in the nursing homes. Next slide. So what have you done? What things have come about with the total isolation that we've come across with COVID, trying to keep our residents safe? And this is a nice picture of, I think, one of the first ways that we in the nursing homes tried to get people visits, and that's through the windows. Next slide. I think we're kind of wanting you to write in a little bit about what other things have your facilities done to help with this problem, with this loneliness, with this isolation, and how are we getting people engaged and visiting with their family despite having to be safe as well. So if you can put in the chat box all the different innovative things that you've done at your facility. We'd love to hear it. I think that's a learning experience, so things that other places can do. And if you'd want to unmute yourself and talk to us that way too, that would be fine. Villa Maria in Fargo has wild turkeys circling the facility as a form of engagement with wildlife. Yes. Tablets with Skype and FaceTime.
Dr. Dahl, this is Kelly, and I'm not sure if I mentioned this on this group's call or on another before, but I had a facility who did visits at a park for their family members. So they would take the residents down to a local park where they could visit their family members. They both stayed in their vehicles, so they still maintained their social distancing, but it was actually an opportunity for them, one, to get out of the facility, and two, to be able to see their family.
Yeah, perfect. I think that outdoor and patio visits were huge. Now I wonder what we're doing with that because of the horrible winters that we get, which actually this winter has been nice to us, so that's been good. But what have we done with those outdoor visits since winters hit? Somebody has a cuddle curtain that has holes in it, and we use long, what's OB cow disposable gloves so they can touch them. Oh, yeah, I've seen some of those with the plastic and hugging in between. Zoom and social media certainly was huge and continues to be huge for this. Live stream local sporting events so that families can watch them. That's a nice way to, a good thing to do, I think. Yeah.
I'm so glad the facility shared their cuddle box, because I had been privy to that idea and just thought that was really, really neat. And I'm sorry, because I speak to so many facilities, I don't remember who did what, but I know another facility created like almost like an outdoor plexiglass visiting area so they could see each other. And they too had slots where you could put gloves on and they could touch each other's hands. And then they used Bluetooth, so there was better sound. And so they could visit, but they could still have that touch even though it was with gloves. So lots of creative ideas out there.
Houses, I think some of those restaurants are using ice houses, so they're setting them up. Oh, it's saying it can't hear me. They're setting up the ice houses or those kinds of things so that they can get outside still and have those meetings. Dr. Jurovich has a good question. Any shared gaming with grandchildren or watching TV? Which that's been the way that my son kept it through Fortnite because they can chat through that. And some more coming in, plexiglass, separator, walkie-talkies between a closed door. So we're coming up with good ways to work around, right? And still stay safe. Keep those coming in. We'll kind of read them off as we go, but next slide, please. I think like we talked about virtual visits and using the Zoom and the FaceTime and all those things have been huge for physician visits as well and APB visits. But good way to connect to family. How did residents seem to adjust to this? I know for my visits with residents, even in the memory care, when at first they really struggled to understand what was happening, they seemed to get it later on. I'm just trying to read some of these. Oh, somebody saw the residents drumming on I saw that on Facebook too, the they were using drums, but they were their exercise balls as a fun activity. All right, next slide. Yeah, so outdoor, I mean, I think you still got to keep safety in mind when we're doing all these different variations of visits. So outdoor visits, you have to stagger visits, make sure you got good airflow so that you can get the bad air out and the new air in, and still be 6 feet apart with masking and all those good things, with lots of use of hand sanitizer. Next slide. And indoor visits, the same thing. And I think that the plexiglass helps separate the 6 feet. Still got to wear the mask, disinfect. Somebody said they had a choir outside with the intercom to get the music in, so that's a good way to keep people connected. Next slide. And some indoor visits, but making sure that there's supervision to make sure that the proper precautions are maintained, especially if you have cognitively impaired residents who don't really understand, and it's harder to keep the masks on in those situations. Next slide. So CMS has continued to take steps to help keep things safe and respond to what's happening. They've issued guidance on how to deal with visitation, reasonable ways that we can safely allow in-person visitation to help with the isolation and loneliness. And I think there are some funds that even you can apply for to help purchase, different iPads, plexiglass, etc., to help the facilities be able to do these things. Next slide. All right. I don't know if there's any questions or other comments people want to make before we move on to the case study.
So Dr. Jervich here. So Dr. Dahl, I think you really came up with an interesting thought, mentioning that study about tracking activity, in facilities that have more social engagement, I believe it was. And that just kind of leads me to think about the opportunities that our collaboration has with creating another PIP, as part of your quality improvement program. If you introduced a new, social engagement program and wanted to track physical activity, that would be an outcome for, improving quality of life for the residents. And so some of the ideas that would come up, to at least to my thinking as a medical director, would be to do things like measuring physical activity with devices that we call accelerometers. And so you would basically get a half dozen of these accelerometers and ask residents to participate in a physical activity program. Let's say, for example, that you had your nurses' aides or whomever visits with each patient to do 5 minutes worth of stepping in place and stand up, sit down type exercises, and then record the physical activity and compare that to another 6 patients that aren't doing that. You can then look at the outcomes to see if there's any differences in terms of their overall physical activity and then fall reduction, any number of parameters that you could look at as part of a PIP process. So really good thought there, Dr. Dahl.
Yeah, and I don't know if who's doing our case study today.
That's me.
All right.
Thank you. And I was thinking of activities too as you were doing that presentation, and just a couple of thoughts I have, not necessarily as physical activity, but just something to get the residents back in some kind of social setting. When I was still in the facility for Halloween, every single year, all of the at least leadership staff would dress up and do a parade through the facility. So you can keep your social distance. The residents could be sitting in their doorway, just something different for them to see and be excited about. Or you could make teams with the staff for a certain groups or themes, so to speak, to dress up, just something different to get them excited. The other thing I was thinking about is that I know when I was in the facility, I always had a beautician that would come in so many days a week. And we had a little area for her to do all the little ladies' hair. Well, I would guess those probably aren't allowed to come in anymore. And if they're not, maybe if you even have a staff member who can just wash hair and fix it for the residents one at a time, obviously coming in and still, you know, wearing all of their PPE, but that's their social time it helps to limit the loneliness or isolation feeling that they have. So those things that you've had to stop doing during COVID, see if there's creative ways you can think about adjusting or adapting them so it will work during this time. So just a couple of thoughts for that. I was looking at Michelle's question, see if anyone else has a response, but as a visitation is starting to be allowed in more facilities, do you have age restrictions on those? That is interesting. See, Dr. Jurovich had responded. No one under 12, Kyle says. Yes, no, that's a very good point. I know that the younger population is a little more challenging to stay masked. I have a 5-year-old and a 2-year-old, and I promise it's a challenge. Both of them thinks it's cool to put the mask on, but they're usually right here within 5 seconds, and we have to pull them up constantly. So, no, that is a challenge. Well, as I'm going through my presentation, I think it would be nice if you all had ideas of new creative activities, programs that you've put in place since the start of the pandemic. I know we talked about it in the very beginning of our program, probably week 2-ish. But if there's anything else that's come up, I think it would be a great opportunity to share with your peers. But we'll go ahead and go through the case study now. All right, so over the past few weeks, we've been talking about specifically the screening performance improvement plan that we've been working on putting together. So we're at the point of looking at monitoring. So we've developed the goal to improve the COVID screening process. We've put these steps and interventions in place, and now it's time to monitor the progress. And just keep in mind, I have the SMART goal on multiple slides here because I think it's important that we know whenever we're monitoring progress, we're trying to meet that goal that we've set in place. You can go to the next slide, please. And as you all know, that monitoring data when you're working on a performance improvement project is essential to be able to determine the reliability of your process and if it has become successful. There's multiple areas you need to monitor. One is that you have completed the action steps that you've put in place. You also need to monitor if it was successful in implementing the process. And then last but not least is comparing your goal to what you're monitoring. So in our case, we were wanting to reduce the COVID outbreaks by 75%. So as we go through this slide deck, I'll be able to show you guys how we're going to track that based on this performance improvement plan. But first, let's look at how we're monitoring the action steps and implementation. Go to the next slide. Perfect, thank you. So these were our tasks that we wanted to do in order to get this plan rolling, which was create a new screening log. On the PIP template that Michelle had provided to you all, there is an option to make sure that you indicate your start date, when it was completed. Whoever you have on your team that is conducting this performance improvement project needs to make a check on this. Depending on what your goal or time frame is on these steps, even up to a daily check on that. If you notice something that wasn't working, I know last week when we talked about interventions and checklists, we said, you know, this, when you're talking with the staff who's performing the screening, they may say, oh, this doesn't work for whatever reason. At that point is when we're going to use this comments lesson learned box. And then it may be something that we really have to stop and recreate the whole thing. And if so, at that point, you can abandon and look at the process again. The same with the screening policy, your designated staff. And last but not least, tracking and testing the change to ensure that it is reliable. Now, I want to look at that tracker that we showed last week real quick. So this is what we looked at last week. And whenever you're tracking that implementation, this is something that you can be looking at to monitor who came in and what, if they were denied entry or not. And as we get to the monitoring based on the goal, you'll see how we tie these two in place. Now, as I mentioned, the goal discusses outbreaks, and we believe the best data would be the actual number of cases and the number of vendors who were turned away. Because if we adjusted and adapted the screening policy due to vendors coming in that were positive and bringing that virus into the facility, we really need to track to see if what we've done has made a difference. So if you look at the total number of patients, new active cases for the month of January, and then we would track all the way through February. And at the end of the February, we could see the total new number of active COVID cases. Obviously, you wouldn't count your people who were admitted with, because that wasn't necessarily the source of the outbreak. They came from the hospital and admitted, if you are accepting positive cases from the hospital. As far as the vendors, you can look, so maybe in the month of January, you had 2 vendors that were turned away based on the screening policy, and it may be in February you had, say, 7. Well, if that's the case, then you were able to catch more things that came up. And we can go to the next slide. And here is the actual monitoring piece that is on the performance improvement plan. So the actual number of vendors denied access to the facility per week. The baseline we have set up as a monthly number, and then we track it each week. And then the final measurement at the end of the month would be what was that week, as well as your total number for the month. So you would compare your baseline number to that final measurement there to determine if that was a successful process. Before we go to our poll, does anybody have any questions or comments about? Oh, and Michelle put in the timeline to a tracking tool, or excuse me, in the chat, the tracking tool for you guys. Do you? And I see Angie had put, she couldn't hear me. Can everybody hear me okay?
Yeah, I think you're okay.
Okay, sorry about that. I didn't have that up whenever I was.
Yeah, that's usually when it's garbage day, I can't hear so well. So the wife tells me to take out the garbage. I can't hear so well. One question I had, Kelly, was by setting a SMART goal of 75% reduction in COVID outbreaks, 75, so it kind of makes me wonder, is it 75% of last month? Is it 75% of the last 3 months? Or 75%? Because, you know what I'm saying is that if you're doing small incremental changes, I think it's kind of like setting your goal is going to be relative to a certain time point. Because let's say, you know, in January, you had 5 cases between staff and residents. So 75% of that number is going to be different than 75% of the last 3 months where you may have had 15 cases. Yeah, is that making sense?
Yes, absolutely. I think that, I guess my idea behind this, and 75% may not be the best percentage to put out there. It may be actually a little less than that. But if you had 5 cases, then the next month, if you only had 2 cases, then you would have achieved your goal. So over the month of February, you track it on a weekly basis just for monitoring purposes, but you're really comparing your January number to your February number.
Yeah. So I think that's the important point, is that you want to look at these changes that occur. So if you're looking at the changes that occur over a week versus a month, I mean, part of the, I guess the issue is that we've been having ebbs and flows in outbreaks. And so that, certainly if you had a sudden surge in cases and outbreaks, that would indicate a critical moment. But let's say like it's even what's happening now. So for example, in North Dakota, the average number of, or not the average, the actual number of cases is trickled down to about 100, down from like 600 per day. So then the question becomes like, well, what impact are you going to have on that 100? So if you want to reduce that down to 50, so wearing masks in public, should bring that down by 50, for example. So that would be your PIP, or your quality improvement intervention, or whatever you plan to do study X cycle. But again, so like you said, what you have here is like two residents had COVID. 75% would mean that 1.5 patients would have less COVID the next round. So you just have to realize that these numbers are sort of what do I say, general guidelines.
Absolutely. And honestly, this goal with the 75% is just an example. It's not written in stone. You really need to look at your facility and what your trends have been to determine what would be a realistic reduction.
Yeah. And then make incremental changes accordingly. So let's say you had an outbreak of 10, you would want to reduce it down to 5, so let's say, or down to 2 if you did the 75%er. Right. And then if you had 2 for the following month, then you'd say, well, we want to reduce it down by 50%. So we want it just 1 and then eventually 0. Right. So they're all small incremental changes.
On a weekly basis. So if you've consistently seen that when you're doing your weekly testing, you're getting 5 new cases every week or something for that example, then you may say, my goal is to have no more than 2 cases per week. So it really is going to be facility specific and what trends that you've seen with the outbreak. This is just, once again, a sample.
Yeah. And it's, by the way, it's applicable to your trends in C. difficile, for example, and influenza. So that all this methodology applies to other infection control outcomes. So I just want to point that out also.